let's segue and talk a little bit now about resistance. So, unfortunately, ultimately the number one reason I think that people come off some of these off of ibrutinib or acalabrutinib is not necessarily because they're having an adverse event. It's that ultimately the drug fails them, right? They progress, and we know from a number of different publications now. There was the seminal papers that documented the CIS481 mutation and the PLC gamma mutations in patients with CLL on ibrutinib. Are you routinely testing your patients for these mutations? And if you are, well, why? And why are you doing that? And then when are you doing it? Are you doing it as you see someone's counts go up? Are you doing it if they don't achieve a CR or they don't have minimal lymphocytosis? Or how do you do that? And I want you to answer so in a non-observation on study. So we were part of this is to try to talk to community physicians about when they should be doing this. And so what are your thoughts on that?
I think first you have to talk about the patient population, which patients are at risk for developing resistance to BTK inhibitors. And I think the population at highest risk for developing resistance are those patients who carry a 17p deletion and or TP53 mutation. And especially if those patients had prior exposure to chemotherapy, even several lines of chemotherapy-based treatment. Those are the patients that we had in the early trials where the remission duration or the median progression-free survival for those patients was less than 3 years. So if you have a patient who fits into that profile, then you have to anticipate that their remission duration is going to be shorter than, probably 2 or 3 years. So in those patients who are considered high risk for developing resistance, there you would monitor the lymphocyte count. You would probably like to see those patients every 3 or 4 months, monitor their lymphocytosis. And I think you are safe as long as those patients have a continuous decline in their lymphocytosis. But as soon as you hit a plateau, or if you notice that their lymphocyte count is starting to trend back up, I think that's the time when you would want to see if those patients are developing resistance by testing. And we can do that here in our lab by testing for BTK or PLC gamma 2 mutations, because we know from past experience that those mutations are in about 8 to 9 out of 10 patients associated with development of resistance. Are they responsible for the biology of resistance? That's another debate, but they are quite good indicators, and they can precede the clinical resistance. But I think testing outside of clinical trials, testing for these resistance mutations on a routine basis, I think that wouldn't really have practical implications and would be more like a clinical trial question, but shouldn't be done routinely. So I think first it's a question of identifying which patients are at risk for developing resistance. I think that's a smaller group of patients, particularly 17p deleted patients, but we shouldn't totally restrict it to those. It's also those patients who had a lot of prior exposure to chemotherapy. 11q deleted patients also can relapse. Patients who have complex karyotype abnormalities, but that's usually not tested outside of clinical trials. So I would, kind of try to focus in on a risk group of patients and then test it at a point which usually would be after 1 or 2 years of treatment, when you see the lymphocyte counts plateauing or maybe starting to climb back up. if that's a clinical situation, you see, one of the key things to re-emphasize is that physicians shouldn't stop the BTK inhibitor, because the majority of the clone is still sensitive. And if you stop at that situation and say, well, we will transition you to something else, and you start them on a small dose of venetoclax, but stop the BTK inhibitor, then patients sometimes can have a pretty explosive worsening of the disease. And for that reason, it's good to overlap treatments rather than stopping the BTK inhibitor.
Yeah, I think those are important points. So we just